Welcome, everyone. This is our fourth episode. We are just chugging along here this summer. But this is our fourth episode of A Dose of Busy, still our third season, so we're really getting into the thick of it. Continuing our series of interviewing some of the vestibular greats and, just doing a lot of, research, clinical research out currently. And so we have our fourth guest today, and this is Dr. Amanda Chiao. And she's coming out of talking to us from El Paso today. And so I'll kind of turn it over to Dr. Chiao and kind of let her give an introduction on, where she is currently. And happy to talk to you. And thank you for coming on to talk to us.
Yeah, thank you so much. I feel like this is also very full circle. So I knew Liz when she was, second year AuD student. I think I met you several thousands of years ago.
Yeah. It was literally, in fact, so we'll kind of give a backstory here. This was, I think this was 2012 or 2013. It was AAA in Anaheim, California. And, I was an audiology assistant at the time, and I was an undergraduate at the time. And so I went to my very first AAA. There was an undergraduate info session, and you were part of SAA. And so I remember that day, and you and Amanda Green, and there were a lot of very fired up students ready to take on this field, and you all certainly inspired me to get involved. So thank you. That you don't realize how big of an impact on me that day.
Well, I appreciate that. Well, it's cool to be able to come back. I don't even know how many years. I don't even want to say the number, but it feels like many moons ago. So I'm thrilled to be chatting with you guys and being your colleague. So a little bit about me. Let's see. I am born and raised here in El Paso, Texas. So I was born here, raised here, and I've been getting to tell my story a lot by saying that I identify as Latina, and it's a big part of I think my story and my career trajectory as of lately. So when I left for high school, I did everything that everyone wants to do when they're 17, 18 and get out of where you're from. And so I trained and did my AuD and my PhD at Texas Tech Health Sciences Center in Lubbock, Texas, after coming from Austin for my undergraduate degree. So really, Texas has been home for a long time. And then I was kind of crazy and was like, let's do a PhD. And so I did. And I know one of the questions is kind of how I got into vestibular. So I'll kind of wait for that here in a second. But I really spent a little bit more time in Lubbock. And then I did a postdoctoral fellowship in Omaha, Nebraska. And that's where I really kind of honed in more on my research. So after many years, I always wanted to come back to Texas because it's home. But I met a boy who kept me there. I was now my husband, so it worked out. Yeah. I came back. We were in Nebraska for a while, where I was a faculty member at the University of Nebraska-Lincoln. I really got my footing there on how to be an independent researcher, which was really powerful for me. And then, and lo and behold, life happens. COVID happened. My perspective changed a lot. And I wanted to come back home to El Paso. And now I'm at El Paso Children's Hospital. I'm also assistant professor in Department of Surgery at Texas Tech Health Science Center, El Paso, which is a medical school. So my career is now 50% clinic, 50% research. And I always say that was always the dream of mine. So I'm truly getting to live a dream and getting to do it at home. So I feel very blessed. I feel very lucky, even though the day-to-day I'm crazy. What did I do? But it's been really rewarding. So that's a little bit about where I work now and how I got here.
Yeah. And Amanda has been, if you've been to any conferences, I feel like Amanda has presented at all of them, and she's an excellent presenter, an excellent teacher, great mentor. And so it's really awesome to see how your career has gone and how you've really kept in good touch with, of course, the patient's perspective, but also in that teaching realm. I feel like I've learned a lot from you, just how we interacted. So I think it's awesome that you're still giving back to students and to patients. Talk to us a little bit about vestibular, because did you know you were going to go into vestibular when you were an undergrad, grad school, or what was kind of that changing point for you?
Yeah, I feel like I'm not like the cool story that was like, I always wanted to be an audiologist. I just really was really bad at speech pathology. And I did my undergrad in communication science and disorders, and I just knew that my heart wasn't really into speech pathology. And I really liked what everyone always really says about audiology. I really like this, like solving the puzzle. I really like the diagnostic side. So that really got me into the field. And no, I had no idea what vestibular was at all. It was actually, I was a first year AuD student. It was my first semester. And I went to my mentor at the time and I said, I hate this, I'm quitting. It wasn't what I wanted to do. I mean, it's true. I was like, I'm not stimulated. And at that point, I was batting a lot of stuff of like, should I go to medical school? And maybe I need to take a step back and do more prereqs for medical school. And a lot of kind of those things that come with it, right? Of like, gosh, but like I got to start over, and how am I going to pay for that? And what is my family going to think? There's a lot of like pressures, and I don't even know how old I was, but I was certainly navigating that, trying to figure it out. And my mentor was like, hold on, because I'm a little bit dramatic. And he was like, hold on, don't like, get crazy. And he said, well, if you thought about a PhD? And I said, no, but okay. So that's really how I got into vestibular, because my mentor was actually a more vestibular cochlear implant medical audiologist. And he trained with Neil Shepard when Neil was at the University of Pittsburgh. And so that's really how my story started. Was my then soon to be PhD mentor was like, I think you would like vestibular. Like, I think it's really challenging. I think it gives you that mix of whole body systems that I think I really crave and I need for stimulation. And like when I'm working with patients. So that's how I got into it. I started exclusively seeing vestibular patients very early on in my AuD program. And the only reason was because I started in the AuD PhD track. So in a way, I kind of got to see a lot of different stuff by nature of my PhD coursework. And I was always there. So I always tell students, you want to see cool stuff, always be around. Because inevitably the cool patient is at 5:00 on a Friday. And if your mentor is like, do you want to come see this? Yeah. And that's how I just got into it. So I would say I'm very much a medical audiologist, and vestibular was something that I kind of stumbled on as I was kind of soul searching, if you will. And I started seeing patients as early as a second year AuD student.
That's awesome. I mean, that's one of the things. I mean, there's so many different diverse backgrounds, and so many people have like their own unique stories of how we all ended up in the same place. And so I love learning about other people's stories. And so now thank you, Karen.
Yeah. Talk to me a little bit, because we get many questions from students who are considering a PhD or maybe have questions about that. So what's kind of your thought, especially looking back on like deciding to do a PhD, or maybe things you wish you would have known before making that decision?
Yeah, hindsight's always 20/20, right? Yeah. And I feel like if I were to look at the younger me, I would have said slow down a little and really figure out what you want to do. I wouldn't change anything, because I think that, it's definitely a part of my story and how I got here. But I think the biggest thing that you want to ask yourself when you think about doing a PhD is, what do I want my life? So not my just job, but my life to look like in 10, 15 years. And that's a big loaded question. But I think when you put it in perspective of life versus professional, it kind of gets to that. I am like, I'm a workaholic. So for me, I was okay with knowing that work came home, or that I needed to do the extra mile, because really a PhD is that when you have to have a really invested interest in being an independent researcher. Not to say that you can't do other things with a PhD, but man, like the work that you put into getting your PhD is a lot. And I see so many students feel that they have to get a PhD to do things like be a director of audiology, or to have other types of positions, or just do research. And I'm like, you don't have to. There's so many other avenues to get to that point. But a PhD is for people who say, I want to ask a lot of questions and I want to solve those questions. And I'm okay with the work that comes behind that. So I would definitely recommend that, have a little bit of a sit down with yourself and be like, is that curiosity in me? And am I okay with my life, involving a lot of work and juggling that back and forth? Because it is very rewarding to do it But as we're talking about earlier before the call started, it's a lot to balance. And so I think that's an important reflection. What do I want my life to look like? I also feel like for me, the PhD was important because I never wanted to hit a ceiling in my career. I love with my PhD that I can do a whole lot of things. I can be a clinician and just never do research again if I wanted to. I could never see patients and just do research if I wanted to. I could teach the majority of my time if I wanted to. I could go work in industry if I wanted to. I could be a director of audiology if I wanted to. There's so many. I can just consult and like work from home. Like I could do so many things, and I really wanted that for myself. That's just something that I knew from the get-go. I never wanted to be kind of held to one type of job.
Yeah. And I think that's a really great distinction that you make too about being the one to ask the questions and being an independent researcher, because it is, I mean, I don't have my PhD and I've considered it a lot, but there's ways you can be involved with research without having your PhD. So it is really looking at holistically, like, what do you want your role to be within research? Because you can still participate with your doctorate of audiology easily. And so if you just want to be involved with research, that's different from igniting and publishing and writing. So I think that was a great distinction.
Yeah. Think about being the leader of it. Do you want to be the leader or do you want to be part of the team? Because I think those are different.
Yeah. And the way you mentioned, like, you got to make sure that you got to make sure that you love it, because you're married to it, and it really never ends. And so there's so many things. Putting that into perspective, it's just not like what do you want like the actual position or the job to look like, but what do you want your life to look like? Just because the two are so intermingled. So that was really exciting.
Yeah. So talk to me. Obviously, we know you have your PhD and you've been in a lot of different facilities where you've done research and been the leader behind that. Talk to us a little bit about some of your recent research that you're focusing on, or what your newest interests are, where your directions that are heading, and how that may be applicable to someone that's in the clinic right now.
Yeah. So I feel like a lot of my earlier research was really focused on the test procedure, like testing itself, vestibular testing, optimizing testing, and particularly for pediatrics. And now I kind of transitioned that work from my postdoc into when I was at University of Nebraska into concussion. So love concussion. I love working with patients with concussion clinically. And the research I think that that I do with concussion, now that I'm beginning to kind of really understand it, is not so much on the testing. I feel like, we're doing that, and it's important to kind of keep optimizing and having almost, I hate to use the word biomarker, but staple distinctions in our testing that look like concussion. That's important. I'm actually really interested in more of the vestibular rehabilitation aspect of concussion and how audiologists play a role in that. More so, I've been doing some work on developing a mobile app. So when we were in Nebraska, there was so many athletes post-concussion with vestibular, visual symptoms. And I was like one person, and I was like, I can't see all these athletes. And we know the earlier that we intervene, the better the outcomes and the prognosis. So we've been working with my team and some computer science folks to develop a mobile app. So this app essentially allows you to prescribe really basic, low-level, low-risk vestibular visual exercises to an athlete based on them. And it kind of auto progresses them. So that way, if you can't see them in a week, they're still progressing in their rehab, and you can actually monitor to see if they're doing it. I love young patient populations for a lot of reasons, but student athletes, oh man, they will tell you they did something, but they didn't, or they do 10 times more because they're super competitive. So having a way to really track what they're doing without having to ask them was really important to us. So we're working on that. So I guess in a way, if I were to call that something, I just want to make concussion, vestibular, diagnostic and rehab more accessible to more people. There's such a disparity. And so we're working with D1 athletes. I mean, they got it. They got a lot.
Yeah.
And a lot of questions I had in the back of my head was like, this is fabulous here. But what happens when I come to El Paso, which I call the medical desert, along with the real desert, because we don't have that. And we don't have people who feel very comfortable with concussion. So my overall goal now with my research in concussion is to make interventions, make diagnostic testing more accessible to different diverse populations who maybe have less access to specialists. people who really know concussion, people who really understand or comfortable treating it. So that's one kind of arm that I'm still working on now.
I have a question about that before we move to the second arm. So I'm curious, especially just on your perspective. So we've talked even like in our last few episodes about audiologists playing a more active role in rehabilitation, like really defining rehabilitation treatment plans and being an active participant, which is well within our scope. But how is that received, for example, on a concussion management team where it's been historically maybe like an athletic trainer or physical therapist that leads rehab? Like how do they accept you, or where are your lines in recommendations?
Yeah, I've been really lucky. I've always been welcomed, I think, in it. And I think it's all about your approach as well. You don't want to come in and guns blazing. It's more about like, here's what I can offer. Here's what you can offer. How do we work together? So interesting with athletic trainer is they don't get a lot of training in vestibular. They don't, hardly. And so I do feel like as an audiologist, especially if you feel comfortable in vestibular, that you have something to say. You have a seat at that table because you're saying, hey, totally get it. You're working with the athlete. You get the functionality. How do I use my testing to support your plan? That's kind of how I've used it. So one thing that I absolutely hate, that's a strong word, what I don't like is that audiologists are like people think vestibular audiology is like, oh, I got one test done and I'm good. I'm like, well, in concussion, utilize us. We can repeat testing to show recovery. We can repeat testing to show progress through rehab. I can build that, and then the PT can build their rehab, and everyone's happy. And so I feel like we are underutilized in that way, and I think it's just a mind shift of audiologists being okay with like, hey, so this is what I'm showing now, and you're going to go see the PT now for 6 weeks of therapy. Let's do a 3-week quick screening, recheck of ocular motility, postural control, and then let's repeat again at the end of discharge. And I think that that's a really great way to complement the physical therapist if they're like, I want to do the rehab.
Yeah.
Because you're working
point too, because I feel like vestibular audiology, and I've seen concussion like quite a few, so maybe this is just our perspective and I agree with you, but it's interesting because vestibular audiologists, we feel very comfortable seeing one and done patients because we're used to stable vestibular lesions where we have a one-time diagnosis and we never see the patient again. But I feel like less commonly seeing dynamic lesions where we want to follow up, where concussion's a prime example. Like I love to follow up with my patients till they're back within normal or that they plateaued to an extent. And I don't know if our model is really used to that because we're not taught to see patients.
I don't think so. And maybe some vestibular audiologists are like, I don't want to. I like that like one and done. I don't with concussion. Yeah. And only because I feel like, especially like our ocular motility, in concussion, everyone's like eye tracking. And I'm like, cool, that's great. What do these numbers mean? Because if I have a sports medicine doc come and ask me, and I have, okay, so how do I use this information to determine if the athlete's ready to return to play? So I think we, as a research, we need to move towards that, right? If we want to do fancier eye tracking, which I think is really cool and really important. But at the same time, our existing measures give us something, like our smooth pursuits. Like we know that smooth pursuit is probably one of the most common abnormalities seen acutely post-concussion, convergence insufficiency. And so a lot of times I would use those very like, look, this is based on your age and your gender, this is kind of where we should see you. And, I kind of would also educate the athlete. And so when I saw them back in 3 weeks and they saw themselves get better, it was actually really good for them psychosocially as part of their concussion recovery. So that's what I would really love to see. And I think how audiology can be really useful in that realm of things. I will also say that on an ideal concussion management team, you have all the players. The reality that doesn't exist. Major medical centers, absolutely. But I can tell you that it is one of the most underserved, just like patient populations in less major, urban areas where there's not a medical center. And so sometimes as an audiologist, if you're really that comfortable with vestibular, you are that advocate, you are that person. So you have two choices. You can say, well, I'm not a PT, or you can say, well, I know the most out of everyone in this room. And I can, within my scope, do something. And I think that's like also an important point for a lot of audiologists who are not in major medical centers with all of the resources. Sometimes we feel like, well, I don't have it, so I'm not going to do it. Well, you could. And what does that look like for your own community? So I do feel like if someone's really competent and feels comfortable, they could serve as even the head of the concussion team. I mean, you want to have a physician to diagnose it, but as far as the rehab goes, I've always seen I've always had a really like good working relationship with PT athletic trainers, neuropsych, and it's really kind of like working together to inform the plan. So a lot of my experience is really in the mild TBI sports concussion area. I would say that the more the severe the traumatic brain injury, probably the more expertise is definitely needed. And that's kind of where I think an audiologist needs to kind of stop and say, okay, this may be outside of my bounds, because those folks are probably going to have a lot more aggressive symptoms that we need to be mindful of during the recovery process. Like for that mobile app, for example, we're not intending it for that to be for somebody who has more than a mild TBI, because a lot of the rehab for concussion is based on graded progression and symptom like tolerance. And so we kind of know for a mild TBI, the traditional trajectory. For more like moderate to obviously to severe, this wouldn't be a good fit. We definitely want more of a kind of hands-on in-person type of approach. Motor veal accident's interesting because a lot of times those tend to have a lot more symptoms than a sports concussion. So I think it really just depends on the severity and kind of where the initial patient is at. So I feel like for those types of patients, maybe more of a group trying to really get all the right players is really important, versus on the sports kind of mild end, we have a little bit more flexibility because there is a lot of natural spontaneous recovery that happens with sports concussion, mild TBIs compared to more severe TBIs.
Yeah, definitely. Super interesting. And it's interesting, Daniel, that you asked that question, because it does seem like majority of the research, I mean, it's just a convenient population to test a lot of athletes because we know the mechanisms of injury are well understood. But I'm hoping that future concussion research does really focus on like the falls and older adult population. That's a really big common cause, and, you know, some of these other mechanisms. So talk to us a little bit, because I feel like I cut you off like 20 minutes ago, but on some of your other clinical interests, or what else is exciting you about your research?
Yeah, I would say the thing that I'm most excited about right now is I have embarked on a new research line, which is looking at ototoxicity from substance use disorders. I really stumbled on this with a colleague, Michelle Hughes, where we got a pilot grant when we were at UNL, and we were like, this is both new area to us, but let's look at potential ototoxicity from substances, illicit drugs, misuse of prescription opioids, alcohol, on both hearing and vestibular function. So we've been doing that grant now for 2.5 years, and I guess that I can officially say it because the check has been cut. But I received an NIH R01 award for a 5-year grant.
Wow, congratulations!
That's super exciting.
It doesn't feel real because I think that's something that was ingrained in my head that like never happened. So I feel the imposter syndrome is real, but I'm trying to based in like the glory of it for now, the exciting part. But what we're having to do for that grant is basically do our pilot work, where we are like using objective physiological measures of hearing and vestibular function in a group of people with known substance use disorders with different types of substances. And we are characterizing their hearing and characterizing their vestibular function. And a lot of our pilot data so far is showing that there are differences in people with substance use disorders compared to people who don't use substances, but it doesn't really follow the traditional ototoxicity pattern for vestibular as compared to hearing. So like our battery is looking like high frequency of hearing, right? That's pretty common with ototoxicity. And we are seeing some of those changes for hearing, no retrocochlear signs, pretty much peripheral cochlear. But for the vestibular, not the case. Vestibular kind of seems really widespread, which makes sense to me. And actually, it's affecting more of the functionality. So DVA and postural control. It's interesting. It's like everyone's like, well, we're doing VHIT, we're doing ocular motor, we're doing CNO vamp. And we tried to make some like hypothesis that were like, oh yeah, like the canals are going to be affected, the periphery. It's not. It's really just more of a central pathway involvement. And actually, like our VEMPs are really interesting because they're showing differences, but I'm not convinced it's an otolith issue. I think it's an input-output pathway issue, which then suggests how useful VEMPs can be from just looking more in the pathway as compared to just like thinking it's end organ only. And so we're kind of seeing those differences right now. So we're super excited for our next grant that we're going to be doing, we're doing the exact same thing, but on 1,000 people across 3 different sites in the United States. So El Paso was one of them, Nebraska, and then also Chicago. And the reason for that was really intentional. I'm really interested in also seeing how factors of race, ethnicity, access to healthcare, how those things kind of put you at a higher risk. So if you are a substance use user, what are the risk factors? If I'm a clinician and I have somebody and I know that they have substance use disorder, I don't want to just assume they're going to have vestibular loss or hearing loss. I want to know, well, what makes you more at risk for it? So we are going to be looking at like their health comorbidity, just general demographics, their income level and how they access healthcare, and then also their substance use patterns. So we're trying to really kind of create like a risk factor model for clinicians. So that way down the line, if you have like on your case history form, some questions about substance use, and there's some very specific questions, it kind of helps you not just feel like you're throwing a dart in the dark, that there could be some reasons as to why this person would be at increased risk for hearing loss or vestibular loss. So yeah, that's what we're going to do. And we just got the award. So we'll be doing that for 5 years. And that's pretty much where my brain will be for 5 years.
Well, it's super fascinating too. And I think like just hearing you talk about it, which I feel like all had these conversations for years, but vestibular is moving so far past just like central versus peripheral. I mean, it's like we are really moving on to these complex disorders like concussion and substance, abuse and use are so complex on the brain, and we don't understand even all the mechanisms for how they interact with the vestibular system in particular. But I think it's really exciting because it's showing maybe the potential use of vestibular in these populations. And also, of course, better outcomes for patients. Like the better we can define a disorder, the better it is for the patient. Yeah. So I think it's super fascinating.
Yeah. And I think a lot from the functional standpoint, as a clinician, I always ask myself, is this question important to answer and can I solve it? The end part. So if I diagnose something, can I help you get better? Because substance use disorder is different, right? If it's not a disorder that only affects one type of person. And in our pilot grant, we really have seen that, and at least in our population in Nebraska, not all, but there are higher incidents for homelessness, higher incidents for lack of insurance, higher incidents for mental health. And so in thinking about what we're doing, we're trying to be really mindful of like, if I tell you have a central vestibular dysfunction, what does that even mean to you? And is that even important? So we're really going to be answering that question in our research and we're asking specific questions like in a questionnaire, like, does your dizziness stop you from being able to get a job? Does it stop you from being able to drive a car safely? One interesting participant told me, they're like, I don't use drugs anymore, but I am so off balance that people won't hire me because they think I'm not sober when I work, when I'm walking down the hall. And we've seen those patients, right? Yeah. Like walking down the hall, and patients on the other side tell us, oh, people think I'm drunk. But in this case, there's such a stigma because this person has a known substance use disorder. How do we reintegrate them back into society? That's where I'm like, I'm not going to solve all of the awesome questions in research, but if I can contribute research in that type of way, then that's what's worth it.
And if anything, that is going to be the most meaningful and impactful question to be answered, especially having that direct impact on their life. I mean, that's what it is.
Exactly. Yeah. You work with a lot of. It's been really cool, like you said, Liz, to just go out of just ENT patients and patients that migraine, love migraine, but like a lot of migraine, right? And so it's just like kind of cool to really work with a very different population and hear their stories and hear their struggles. It's been really refreshing. And again, I think all in all, I'm really trying to target my research to things that serve me as much as I serve research. And that's kind of like my motto now. As a researcher and clinician, we're doing a lot of giving. We're doing a lot of things for our field, but it has to serve you as well. And for me, targeting research that is for underserved populations is a really, really passion of mine. So it's really cool that I get to do research in the neighborhoods that really raised me. I grew up here, so this is the first time we're going to do some really cool research in predominantly Hispanic populations, El Pasoans. And so to me, it's really empowering. So I'm really excited to do the work and see what comes from it.
Well, and I think it's very obvious that you are blazing a trail because it's been known in vestibular that we have a very biased research population that all of our research has been published in. So even just, I always get very inspired listening to your talks at conferences and anytime I read anything, just because I feel like you are pushing yourself out of what has been a typical clinical setup and trying to really like access these populations that we wouldn't traditionally access and also make our services more accessible to them in that capacity from rehab and treatment. So I just think it's really, really cool. I am curious. So we will share a couple of your articles of your choosing with everybody that listens to this. That's what we're doing every episode. So you'll get to read a lot more about what Amanda has done in recent years to contribute. And please read up on it because it's just like, I think the most fascinating and useful research. From your perspective and just looking at vestibular as a whole, where do you see the field going?
I feel like the field is going a little bit towards what you were saying. Expanding vestibular to be accessible to other unique patient populations, concussion, ototoxicity, things that we kind of know, but we don't really really dig deep into. I do feel that. I feel like, as we're working towards the vestibular implants, like a lot of that research, I'm really excited about that. I think that could be really cool part of audiology that really blends really nicely from our sister cochlear implant research field. So I do feel like I'm excited to see that grow in that area. And I think that's coming, probably the next 10 years for sure. And then what I guess I'm hoping that I see for the future is truly about getting clinicians to not feel like they have to have all the bells and whistles to be a competent vestibular clinician. I think that's really important. Sometimes when we go to conferences, and I can see in some patients or some people, clinicians like, well, we don't have that. We don't have a rotary chair. We don't have that. And what I really love about manufacturers now is that they're like saying like, well, you could have this and it has like these modules on it and you can kind of do this. So just it's not like how it used to be back in the day where this was a standard full balance assessment and vestibular assessment. The fact that we can be flexible now and really start to not just do the test to do the test, but to do it because it's needed or to do it in a way that gives us a piece of an answer, I think is really important. So I'm looking forward and I hope I see that there's just a lot more of like accessible vestibular testing, different ways to test the vestibular system than just relying on what we think, that we need to have all the bells and whistles to do it.
It's so funny that you're talking about this and you haven't listened to it and nobody's listened to it yet, but as at the time of this recording, but our previous episode interviewed Daniel because he just got back from a trip in Poland and talking about like, you can still have a competent vestibular assessment with very limited, and we were really discussing like it's great when you have everything, but you can still do your job with less than ideal conditions for testing.
There are so many great alternatives, and you will know what they are, and but we get stuck in this mindset where you have to have X, Y, Z in order to fully measure the vestibular system. But there's so many great things that you can do, low cost, low tech that are that are going to catch those large, at least,
Yeah, definitely. One of the best advice I ever got, I trained with Neil Shepard for 3 months at Mayo, and it was incredibly life-changing for me for a lot of reasons. But he told me, he was like, the best test that you're going to do is your case history and your vestibular bedside. Do it really well. He said, it has to make sense. Your patients are not going to lie like that. Like, it has to just make sense. So I default a lot to my case history. I take a long time on case history, and I take a long time on vestibular bedside and a neuro exam. And I do that because I guess he's always like, trust your eye, trust your gut. And so I think there's a lot to be said about that. At ABS, we had, our featured speaker, and he was talking about like, just do a really good bedside and see what you see. And I think that's really good reminders of like, we don't need all the bells and whistles sometimes. If we have it, it is nice, but it shouldn't stop you from being able to at least initiate services and get started.
It's a good confirmation, but it doesn't have to be a crutch for like not performing something. And I think that's a really good reminder. And I love what you said too about, and this is obviously a trend with how you're directing your research, But I think we're getting better about testing with a purpose. So if we can't make a specific recommendation on a test, why are we doing it? Or if it doesn't make a difference in the diagnosis, why are we doing it? And that's a very big deviation, I think, from how vestibular used to be. And a lot of times maybe we're constricted by like codes we can build here in the US, et cetera. But I think like times are changing where we want every test to have a purpose for the patient's diagnosis and also for their functional performance. Because if we can't help PT and say, here's what to do with this abnormal result, and that's always just the start of research. We always, develop the test and then figure out the rehab. So sometimes it's a little painful between those two areas. But I think it's a great reminder that we should be testing things that can make a difference to the patient's life.
Yeah, definitely.
Okay. I know you've already mentioned a million pieces of advice for students and clinicians, but any last minute advice for a young clinician, someone that's just getting started, or maybe someone that's still studying to be an audiologist?
There's so many, because I feel they're all like my mistakes. So I will say this, like Danielle and Liz are welcome to share my email because I feel like that's a part. I don't teach students anymore, but I love to mentor students, career-wise and just professionally. As a minority, I feel like I've learned a lot differently. And so I would say this, trust the process. Trust the process. Trust being okay with not having it perfect right away. Trust the falls, trust the highs, just like literally trust the process. It'll all work out. It always does the way it's supposed to. I think I was always so cognizant of like being perfect every step. So workaholic perfectionist type A is me. And I feel like now in my old age, my 30s, I feel like I have really embraced like I did the best that I could. That was the best that I could do. And I will often tell students that work your butt off, be the best that you can. So when you walk out that day, you did the best that you could. And that's all you can do. So trusting the process and knowing that you'll get the tools at the right time when you need them to do what you want to do, because it all works out, because it always does.
Yeah, I mean, that's absolutely wonderful advice. Can't let perfect get in the way of good enough.
Yeah, exactly. Yeah, especially if you really want to serve in areas, the communities that are not these major medical centers with all of the tools and resources in front of you. Just what you said, Danielle, my husband reminds me of this all the time. He's in our pediatric ENT here, and he, I'll kind of vent to him and like, oh, but our protocols and we need this and all of that. And he's just like, but you're getting it done. Don't let it stop you from starting, from doing. And there's a lot to be learned by just the act of doing versus always trying to prepare or plan for it. So I think it's a really good reminder of just you do what you can, and every little bit counts.
Well, thank you for I am excited to already listen back to this and all of the advice that you gave. And I feel like every single episode Danielle and I record, it reminds us how accepting I feel like the vestibular community is to help mentor young professionals. I feel like everybody we've ever interviewed is like, reach out to me and if they need help. And we feel that way too. So we appreciate that our community keeps up at least this really serving nature to the future, because it helps all of us. So thanks for being open to that as well.
Yeah, absolutely. I'm an open book, and I feel like I have a lot to share. Even if I don't have the answer, my goal is to always put you in touch with somebody who does. So.
Oh no, you have so much to share. Your story is so unique. Thank you for sharing it with us, and really just thank you for continuing to just be forward thinking and really pushing this field forward, because we certainly need a lot of them.
Yep. Well, that wraps up our episode 4. Check out, of course, our Instagram and Spotify and everywhere we listen to podcasts. We're going to have some articles that Amanda's going to share about things that she's published or projects she's been participating in that she thinks are the most useful to share with you. And now when you read her name, you'll know a little bit more about her. And of course, if you have any questions, we always accept them via email or via our Instagram, and we can pull Amanda in for any expert answers on that. So thanks for listening, and we will see you next month.